Hello students, I am Dr. Sylvester Justin, Assistant Professor, Department of General Medicine from Sri Lakshmi Narayana Institute of Medical Sciences, Pondicherry. And today I'm going to talk about Introduction to Endocrinology and the disorders of hypothalamus. So we will have an endocrinology overview and we'll proceed with hypothalamus in particular today. Let's get started. Hormone. The word hormone means to set in motion. So it has many dynamic actions. And, thus the name itself implies that. Hormones can be endocrine, which means they are secreted internally into the blood. Or they could be exocrine, which means they are secreted externally into a lumen. And they can be paracrine, that is action on adjacent tissue. For example, somatostatin from pancreatic delta cells inhibits insulin secretion from nearby beta cells. Finally, hormones can also be autocrine, that is, they may have action on the same cell which produces them. For example, insulin like growth factor 1 acts on chondrocytes, breast epithelium, and gonadal cells, all of which produce it also. Hormones are involved in intermediary metabolism, reproductive physiology, bone metabolism, and growth. So all important functions for life, hormones are involved in. So this is an overview of the endocrine system of the body. So starting from hypothalamus, which secretes thyrotropin releasing hormone, corticotropin releasing hormone, growth hormone releasing hormone, dopamine, somatostatin, and vasopressin. Then we have thyroid and parathyroid glands secreting their namesake hormones. We have liver also as an endocrine organ, in that it secretes insulin like growth factor. Then adrenals secrete the glucocorticoids, the androgens, and adrenaline and noradrenaline. We have kidney, which also is an endocrine organ in the sense that it secretes calcitriol, renin, and erythropoietin. We also obviously have the testes and ovary, which secrete androgens and estrogens respectively. Uterus also is able to secrete prolactin and relaxin. Moving ahead, we have pancreas, which secretes insulin, glucagon, and somatostatin. Stomach has a number of endocrine organs found recently, like gastrin, ghrelin, histamine, somatostatin, and neuropeptide Y. Thymus has thymopoietin. And finally, we have the master gland of this endocrine orchestra, pituitary gland, which secretes growth hormone, thyroxine stimulating hormone, adrenocorticotropic hormone, follicle stimulating hormone, myocyte stimulating hormone, luteinizing hormone, prolactin, oxytocin, and vasopressin. Finally, we also have pineal gland, which secretes melatonin. So today we will learn about hormone secretion, hormone action, hormone regulation, endocrine diseases, their evaluation, treatment strategies, and we'll also discuss about hypothalamus in particular. Coming to hormone secretion, before we go into that, let's know about the structure of hormones and their synthesis and their processing. Then we'll talk about how they are secreted, transported, and how the action is brought to an end by degradation. So structure-wise, hormones can be amino acid derivatives like dopamine, catecholamine, and thyroid hormones. They can be small neuropeptides like GnRH, TRH, somatostatin, and vasopressin. It could be large proteins like insulin, LH, PTH, and GH. They could be steroid hormones like cortisol or estrogen, and they can even be vitamin derivatives like vitamin A and vitamin D. Neuropeptides typically act on G protein coupled receptor. Angiotensin 2 is an octapeptide, so a protein made up of 8 amino acids, whereas oxytocin and vasopressin are nonopeptides. The hormone synthesis usually proceeds in this way. First, from DNA, mRNA is generated by the process of transcription. Then they enter the ribosome, and the protein called pre-prohormone is secreted. And then they go to the endoplasmic reticulum, where they are subjected to cutting and splicing, and we get prohormone. Then they go to Golgi apparatus, where they further undergo changes, and from there we get the mature hormone, which are stored in secretory vesicles, waiting for the stimulus for them to be secreted. Regarding steroid hormones, it is by a process called steroid biosynthesis. So it all starts from cholesterol, and it goes to pregnenolone, progesterone, deoxycorticosterone, corticosterone, and aldosterone. In case 17 hydroxylation takes place, it goes to other hormones. Ultimate end result will be dihydroepiandrosterone, androstenedione, testosterone, dihydrotestosterone, and estradiol. We'll also get cortisol as an outcome of this steroid biosynthesis. Another unique hormone is thyroxine. So here we require an element iodine to be trapped by the follicular cells of thyroid gland, and there they are conjugated with these amino acids to form triiodothyronine and tetraiodothyronine or thyroxine. They are stored in conjugation again with thyroglobulin, waiting for the signal for them to release. So hormone transport and degradation dictate the rapidity with which a hormonal signal decays. For example, somatostatin exerts effects in virtually every tissue. So a short half-life allows its concentration and action to be controlled locally. TSH action is highly specific for the thyroid gland. Its long half-life accounts for relatively constant serum levels, even though TSH is secreted in discrete pulses. So TSH, even though it may have a circadian rhythm, because of its long half-life, it doesn't matter when we test for it. So that is the importance of half-life. Hormonal half-life is also important in achieving physiological hormone replacement, because the frequency of dosing will be linked to the half-life. For example, T4 has a long half-life of 7 days. So to reach a new steady state, 1 month is required. But on the other hand, a single daily dose is sufficient to achieve constant hormone levels for the day. T3 has a short half-life, and it must be administered 2 or 3 times a day. So if you want to treat hypothyroidism with thyroxine, OD dosing is sufficient. But if you are doing it with T3, then 2 or 3 times a day, you will have to dose it. Also, T4 will take a longer time to achieve a steady state. T3 will achieve a shorter time. Coming to hormone actions, here we will learn about the receptors and the types, and further downstream signaling from the receptor. We'll learn about action on the tissues, and we'll finally learn about the functions of the hormone, which as I said earlier, is maintenance of homeostasis, its growth, and its reproduction. So it's important for life, for the well-being of the individual as well as for the propagation of the species. So coming to the receptor types, G protein coupled receptors. So this is one of the most common types of receptors. Hormones used, it has 4 types: GS alpha, GI alpha, then the calcium channel type, and the G11 G alpha type. So GS alpha, the hormones dependent on this is beta receptor of adrenaline, LH, FSH, and TSH. And signaling is via increase of cyclic AMP. Further downstream will be protein kinase A. Glucagon, PTH, PTH related peptide, ACTH, MSH, growth hormone releasing hormone, and CRH. All of them act via calcium type channel of GPCR. Signaling is via calmodulin. Further downstream by calcium dependent kinases. GI alpha, the alpha receptor of adrenaline, and the hormone somatostatin. They act by decreasing the cyclic AMP concentration. And the TRH and gonadotropin releasing hormone, GnRH, act via the G alpha G11 type of GPCR, and signaling pathways via phospholipase C, diacylglycerol, and inositol phosphate 3. Other types of receptors include tyrosine kinase receptors, on which insulin and IGF-1 act, cytokine receptor linked kinase, on which growth hormone and prolactin act, and serine kinases, on which some minor hormones like activin, PGF beta, and MIS act. So here we can learn about the 2 main types of hormones. One is where the ligand joins the receptor on the cell membrane, like we saw now, the protein coupled receptor or an enzyme linked receptor. And after activating it, there is downstream signaling to a second messenger, and then some enzymes like protein kinase are involved further downstream, and then they act upon whether the nucleus or organelles or cytoskeleton. But the other type will be the lipophilic ligand, like a steroid hormone, which can enter through the cell membrane into the cell, and there it may act in some cytoplasmic receptor, or it can directly go even up to the nucleus and act on the nuclear receptor, where it will bring direct change in the DNA or in the DNA promoter to cause its effect. So basically, we can have a lipophilic ligand or a lipophobic ligand which acts on a cell membrane based receptor. So again, that's what it shows. The endocrine system can have a water soluble ligand which acts on the cell membrane based receptor, or a lipid soluble hormone like a thyroid or steroid hormone, which will enter right up to the nucleus and bring about its action. This is another slide showing the G protein coupled receptors types: alpha S, alpha I, alpha Q bar 11, and alpha 12, 13. This is another slide which is showing the classification in another way. Class 1 is steroid hormone receptors. Class 2 is RXR heterodimers. Class 3 is homodimers, and class 4 is monomers. Calcitriol, so vitamin D. Here, this hormone acts by entering into the cell, attaching to its receptor, and then this complex acts upon the DNA to bring about its action. Similarly, glucocorticoids is another steroid hormone, enters the cell, and intracellular it reaches up to the nucleus to bring about its action. Now that we have seen the types of hormones and the receptors, let's look at what are the main endocrine organs and what are their functions. So hypothalamus, its function is to release the releasing hormones, which go and stimulate the pituitary activity. Pituitary releases the trophic stimulating hormones, which stimulate thyroid, adrenal, gonadal, and pancreatic activity. Thyroid hormones release thyroid, which are necessary for metabolism, growth, and development. Adrenals secrete corticosteroid hormones as well as catecholamines. and they regulate metabolism and behavior. Pancreas secretes insulin and glucagon, which help regulate the blood sugar levels, and the gonads, they secrete the sex steroid hormones, which are necessary for development, growth, reproduction, immunity, and onset of puberty and behavior. Hormone regulation. So it is by methods of feedback control, negative feedback or positive feedback. Also, pro-hormones, binding proteins, the way they are degraded, and receptor desensitization and hormonal rhythm are other methods to help regulate the hormones. A very small quantity of hormone is able to bring about big effects. So we require so many regulating mechanisms so that we can have a very tight regulation and nothing goes out of control. For example, hypothalamus secretes TRH, which helps anterior pituitary secrete TSH, which helps thyroid secrete thyroxine, which goes back and gives negative feedback and inhibits the anterior pituitary and hypothalamus and completes this feedback inhibition loop. Another example, hypothalamus secretes GnRH, which helps anterior pituitary secrete FSH and LH, which helps ovaries to secrete estrogen and progesterone. And most of the time, this also goes and has a negative feedback on pituitary and hypothalamus. Here we can also see an example of positive feedback in the body, where in the menstrual cycles, in the mid-menstrual cycle, about day 12 to 14, this estrogen and progesterone, instead of causing a negative feedback, causes a positive feedback and causes further increase in GnRH, FSH, LH, and further increase in estrogen. This leads to the LH surge around day 14, which helps in bringing about ovulation. So this is again showing the hypothalamo-pituitary axis. From hypothalamus, the capillaries form a venule and again become capillaries in anterior pituitary, forming the portal venous system. Hypothalamo-pituitary portal venous system. This helps in making sure that the signal sent by hypothalamus is received by the anterior pituitary. For the posterior pituitary, no such venous system, portal venous system is required because the posterior pituitary does not have cell bodies of their own. They are basically axons of cell bodies located in the hypothalamus. So instead of the signaling going via blood, the signaling goes via their own bodies, the cell bodies, the axons from the cell body to the releasing site in posterior pituitary. So this is our endocrine system at a glance. This is the endocrine symphony, and the conductor, the master gland at the top is pituitary gland. It helps in acting upon the liver, mammary gland, thyroid gland, adrenal gland, and the gonads. It also, via posterior pituitary, secretes antidiuretic hormone or vasopressin to bring about water balance by acting on kidney, and also it secretes oxytocin, which helps in milk ejection, that is milk let down and uterine contraction during labor. A schematic diagram showing the same thing again, the endocrine symphony. This is showing a pre-pro hormone, pro-opium melanocortin, which is further broken down into ACTH and beta lipoprotein. So this is how pro-hormone becomes a mature hormone. Another example of insulin, a pre-pro-insulin loses a signal sequence to become pro-insulin, which loses a C-peptide to become mature insulin, which looks like two strands of amino acid joined together by disulfide bridges. Apart from this, there are binding proteins like thyroxine T4 has thyroxine binding globulin, and thyroxine binding pre-albumin and albumin. T3 has TBG and albumin again. Cortisol has CBG, whereas the sex hormones have sex hormone binding globulin. IGF also has IGF binding proteins. So all this helps in giving one more further store for the hormones before they can bring their actions. Finally, there can be circadian rhythm, which is there for most of the hormones. But for thyroid functions, you may not notice that because of the long half-life, as we discussed before. But most importantly, for cortisol, circadian rhythm is very important. It peaks between 8 a.m. and 9 a.m. So whenever you are going to do any testing on cortisol, you are supposed to do the testing between 8 a.m. and 9 a.m. So all these things help in regulating the hormone action. By binding it to some binding proteins, we can reduce the concentration of active hormones. The body reduces the concentration of active hormones. Similarly, by having a circadian rhythm, it helps in setting the cycle again the next day. Similarly, if there is excess of a hormone, the receptors themselves may become desensitized and thus save the body from overaction of the hormones. In spite of all these regulatory mechanisms, the feedback mechanisms, the binding proteins, the circadian rhythms, the receptor desensitization, there may still be sometimes hormonal deficiency or excess. Other type of disease could be hormone resistance, where the hormone is present in the normal amount, but the end organ is not able to act. So these are the main types of endocrine diseases. So if you see, the deficiency of thyroid hormone will cause hypothyroidism or goiter or both, whereas excess will cause hyperthyroidism. Vitamin D deficiency will cause rickets or osteomalacia. Insulin deficiency will cause diabetes mellitus. And similarly, sex hormone deficiency will cause hypogonadism and amenorrhea, and growth hormone deficiency will cause short stature. So here again, we are juxtaposing the excess and deficiency. So insulin deficiency is diabetes mellitus. Excess in the form of an insulinoma, for example, will cause hypoglycemia. Thyroid hormone deficiency causes hypothyroidism. Excess causes thyrotoxicosis. Parathyroid hormone deficiency causes hypoparathyroidism. Excess causes hyperparathyroidism. Vasopressin deficiency causes diabetes insipidus. Excess causes syndrome of inappropriate ADH secretion. Similarly, pituitary deficiency of any one hormone causes hypopituitarism. Deficiency of all the hormones causes panhypopituitarism, and in case of a tumor, it will have a hormonal excess. Some other diseases could be specific to endocrine system. For example, multiple endocrine neoplasia, where more than one endocrine organ is affected by hyperplastic and neoplastic growth. There are some specific types like type 1 Wermer syndrome, which has a triad of parathyroid, pituitary, and pancreatic tumors, and type 2, where parathyroid, thyroid, and pheochromocytoma occurs. And the thyroid tumor is usually medullary thyroid carcinoma. There's a type 2A called Sickle syndrome, type 2B, which is also known as MEN3, in which hyperparathyroidism is not seen. The other two are seen, pheochromocytoma and medullary thyroid carcinoma. And along with it, marfanoid habitus, mucosal neuromas, and some other findings like medullated corneal fibers are seen. Nowadays, a type 4 men syndrome is also being recognized, which is like type 1 in having parathyroid, pituitary, and neuroendocrine tumor. In addition, it has gonadal or renal tumors also. Non-endocrine disease affecting exclusively the endocrine glands would be autoimmune diseases like the autoimmune polyendocrine syndrome, which causes destruction of endocrine glands, more than one. gland in an autoimmune way. So there are autoantibodies affecting them. All of this will cause deficiency of the particular hormone, except in case of thyroid gland, where these autoantibodies could actually be a stimulating antibody, leading to Graves' disease. So coming to evaluation, the earliest clue will be given by the clinical features of the particular hormone. Then we can also do direct examination of the gland. Only two glands are amenable for that. One being the thyroid gland in the neck, where it is accessible. Another being the testis in males. Coming to hormonal measurements, yes, we can do the plasma or serum and urine hormonal assay. We can do basal hormone testing. We can do dynamic testing. That is, we could stimulate or suppress the hormone and find out how they react to it. Finally, we can do radiological imaging to find out the location of a tumor. Treatment strategies. Deficient hormones will have to supplement from the outside. Excess hormones will have to suppress. And if there's a tumor which is causing the problem of excess hormone, then if it is amenable to surgery, we can remove it. Now that we have had this overview of endocrinology, endocrine system, let's discuss about the hypothalamic disorders in particular today. So hypothalamus is the command center for hormone regulation. From there, it gives signal to pituitary, which further goes on to act upon everything: thyroid gland, ovaries, testes, adrenal gland, everything. Now, numerous dysfunctions of hypothalamus can occur, and this will cause what? This will cause problems in body temperature, in growth, in weight, in water balance, in milk production, emotions, and even the sleep cycles may get affected. So hypothalamus is very important. Before we go into the disorder itself, an outline of its anatomy. So there is an anterior region, there's a middle region, and there's a posterior region. Anterior has 5 nuclei: preoptic, paraventricular, supraoptic, suprachiasmatic, and anterior hypothalamic nucleus. Middle has 3 nuclei: arcuate, ventromedial, and dorsomedial. And this middle is situated just above the tuberous medium and infundibulum. Posterior region contains 2 nuclei: the posterior hypothalamic nuclei and the mammillary nucleus, which is present in the mammillary bodies. So, coming to the preoptic nucleus, the primary function is to secrete GnRH for sex hormone regulation. Paraventricular nucleus, it secretes predominantly oxytocin, also secretes vasopressin, and also releases CRH and TRH. So 4 hormones are released by the paraventricular nucleus, but most importantly, oxytocin. Supraoptic, it is similar to paraventricular nucleus, but here predominant secretion is of vasopressin. So paraventricular was oxytocin, supraoptic is vasopressin. Then there's suprachiasmatic nucleus. So it is receiving direct input from the retinal ganglion cells and synchronized body functions with periods of light and dark. It projects to the pineal gland, which secretes the hormone melatonin, a sleep-inducing hormone. So that's understandable. The optic chiasma is there, so the light is perceived by the eyes, and it relates to this nucleus, which is just situated above the chiasma, suprachiasmatic nucleus, and that goes and shares the information with pineal gland, which secretes melatonin, so that the person can sleep during the dark. And finally, there's anterior hypothalamic nucleus, which helps in body temperature regulation by cooling the body. Coming to the middle region, we have the arcuate nucleus secreting GHRH and prolactin inhibiting hormone, which is dopamine. And there's the ventromedial nucleus, which is the center of satiety or fullness. Dorsomedial nucleus is an emotional response center. Finally, going to the posterior region, we have the mammary nucleus, which is part of the limbic system that is responsible for memory, behavior, motivation, and degeneration of it occurs in Korsakoff syndrome. Finally, we have the posterior hypothalamic nucleus, again participate in blood pressure regulation, pupillary dilation, and thermoregulation, and it causes increase of body temperature, for example, by shivering when a person is feeling cold. So what are the causes of hypothalamic dysfunction? Brain surgery, obviously, traumatic brain injury, brain tumors, history of radiation or chemotherapy, nutritional deficiencies, brain aneurysms, some genetic disorders like Prader-Willi syndrome and Kallmann syndrome, infections, inflammatory diseases like multiple sclerosis and neurosarcoidosis, paraneoplastic syndromes, also rapid onset obesity can cause hypothalamic dysfunction, hypoventilation, and autonomic dysregulation syndrome. So the majority of the hypothalamic dysfunction syndromes affect the hypothalamic pituitary adrenal axis. Many disorders produce hypothalamic hyposecretion, which causes pituitary hyposecretion. And disorders affecting the hypothalamus will mostly affect the neurohormones vasopressin and oxytocin, which are basically secreted from the hypothalamus themselves. So clinical features will depend on what hormonal deficiency occurs. GnRH, for example, if the lesion affects that nucleus, which is like preoptic nucleus, it can lead to anovulation and amenorrhea in the women. This hypothalamic amenorrhea women typically are very thin or muscular with deficient adipose tissue. They may also present with Lanago hair, anxiety, and amenorrhea. And Frolic syndrome is a disease which causes excessive eating and associated with obesity and delayed puberty. It's a genetic disease. It is caused by trauma or tumors affecting the, it's not genetic disease, it's a disease caused by trauma or tumors affecting the eating centers and the secretion of GHRH and GnRH. The patient presents with short stature and small testes. The nuclei affected are arcuate, preoptic, and ventromedial. Kallmann syndrome produces delayed puberty associated with anosmia. It is caused by reduced production of GnRH. In a patient with central hypothyroidism, symptoms will include fatigue, weight loss, and the other symptoms of hypothyroidism. Adrenal axis patients, where their adrenal axis is affected, they will have symptoms similar to Addison's disease. So basically, whichever hormone is affected in the hypothalamus, the corresponding disease will be seen. Also, children with hypothalamic dysfunction will present with short stature, obesity, hypothermia, hypodipsia, developmental delay, generalized seizures, gelastic seizures, where a child may have seizures looking like bouts of laughter, and a delayed puberty, although there may be sometimes precocious puberty. So there's a condition called hypothalamic hamartoma, which causes gelastic seizures, and the syndrome is called as Hall-Pallister syndrome. Coming to investigations, obviously hormonal profile will have to be done, sodium levels and blood and urine osmolarity for seeing the vasopressin involvement, and we can do brain imaging via MRI or CT. We can do a visual field test to know about compressive effect of the tumor on the optic chiasm. We can do genetic analysis, for example, in the Kallmann syndrome and Prader-Willi syndrome. And we can check for autoimmune markers also to see any autoimmune destruction of the gland, hypothalamus. Treatment for tumors, surgery or radiation will be required. And for hormonal deficiencies, they have to do hormonal replacement. Froelich syndrome, for example, in males, it's treated with human chorionic gonadotropin and testosterone. In females with estrogen and later with estrogen progesterone. Kallman syndrome requires lifelong sex hormone replacement. Nutritional guidance may also be required. Finally, we may have some differential diagnosis to do. For example, whether it's a pituitary dysfunction or a hypothalamic dysfunction. Also, if it is diabetes insipidus, we'll have to see whether it's nephrogenic or central. For example, if it's a genetic abnormality causing hypothalamic dysfunction, like Prader-Willi syndrome, which can also cause increased appetite. Hyperthyroidism can also cause hyperphagia. So we will have to decide whether it's an endocrine disease in the form of a primary hyperthyroidism or it's a genetic disease. Finally, we may have to rule out whether the person has substance use or use of some stimulants or use of or having psychiatric conditions, all of which can mimic certain hypothalamic disorders. So we have to do a good history taking and clinical examination. We have to send the correct hormonal profile and we have to interpret it to come to a correct diagnosis of whether it's the hypothalamus involved, whether it's the pituitary involved, whether it's the other endocrine organs further downstream involved, which is causing the problem. And based on that, we can do the treatment. Thank you for your patient listening. We'll deal with more of the endocrine diseases in the subsequent classes.